Hello and welcome to the European Respiratory Journal podcast. My name is James Chalmers and I'm the chief editor of the European Respiratory Journal. And I'm delighted this month that we're joined by my colleague, Professor Sanjay Chotirmall, who's Vice Dean for Research and a professor in molecular medicine at NTU in Singapore. And we're going to be talking about a really exciting study that we've just published in the ERJ on residential exposure to Aspergillus and the association with exacerbations of COPD. And Sanjay's had a very productive month with the ERJ because we've also published a review on fungal lung disease that is also coming out in the ERJ, on which Sanjay has led. So we're going to be talking about fungal lung disease. So welcome, Sanjay.
Thank you, James.
So let's start with the study that you've published on exacerbations of COPD. I think this is a question that people have had for a while, is how does patients' environment potentially impact on risk of exacerbation? Tell us what the study shows and what you think the implications are.
I think the study, first of all, clearly shows us evidence that the home environment contributes to respiratory outcomes in COPD patients. Thinking of it on a broader scale, I think we're very familiar with this in other respiratory diseases such as asthma, where I think triggers have commonly been identified for asthma attacks or deterioration in clinical status. However, in the context of COPD, that's not traditionally thought to be a disease of sensitization or allergy. This is somewhat new. But this is also premised by a number of papers that our group has published in the ERJ over the last 3 to 5 years, which has already started to show that perhaps the kingdom of fungi have a clinical role in this disease. Starting with a paper by Tu et al. Showed that in fact, fungi in the outdoor air was inducing measurable immunological reactions in patients with COPD. In fact, those who had those measurable reactions tended to be more frequent exacerbators needing hospitalization. That prompted us to do a study in the patient's home, in a patient's environment, to understand how that direct relationship may work in an indoor setting rather than a broader outdoor setting. And using next generation sequencing techniques and advanced sequencing of low biomass air samples, we are able to conclusively show that in fact, even a very small amount of Aspergillus species in your own bedroom air environment has a direct link with COPD exacerbations.
For our listeners, this will be quite an exciting and interesting approach. Just talk us through how you obtain samples for sequencing from air in people's homes. I mean, that logistically must be quite an extraordinary effort.
I think the first thing to say about air is it is a very low biomass sample. So compared to any human specimen that we take, even lavage that we say is grossly diluted with saline, we still have a lot more DNA in a lavage that's diluted than you would in the air. So the first thing that needs to happen is an air collection protocol would need to be optimized in order to get enough DNA template to even perform the sequencing. And in fact, we're the beneficiaries of some excellent work done at NTU Singapore over a number of years to essentially optimize that pipeline. So we've optimized it as collecting at a speed of 300 liters of air per minute for a period of 8 hours, and that will give you enough template. The second feature of optimizing such a pipeline is the fact that the DNA concentration in air varies throughout the day. And so that makes it even more tricky as to the time in which you sample to ensure you're getting enough template. So a lot of that is pre-optimization steps that happened over many years, far before even we could ask this question and perform this study. We would collect that air, it would be collected onto a filter, which then gets DNAs extracted from that and sequenced and put through a bioinformatic pipeline in order to determine that air microbiome. But in this study, we went beyond just the indoor air. We concurrently collected and sequenced outdoor airs by putting the same filter on the balcony of the residence, as well as swab a surface in the room and sequence that. And that was then correlated with the host microbiome, which was done through the standard processes that is very well established and published in the literature.
Yeah, fantastic. Enormous effort to get these samples and to be able to study this. What do you think are the implications of this for patients and in terms of what the next studies will look at? I'm thinking about, the asthma literature, for example, house dust mite sensitization is a risk factor for exacerbation, but avoiding these things is very difficult because they're everywhere. I often will say to patients, Aspergillus is everywhere. It's very difficult to avoid, which is why we need to treat your Aspergillus sensitization with medical treatment. Do you think there's a scenario where modifying the environment could be a way in which we treat or prevent COPD exacerbations?
That's a very interesting concept to think about. I think the aim of this study was to, first of all, conclusively show that aspects of the indoor environment influence clinical outcomes. And that then obviously opens the door to the question you just asked, which is, can we have interventions in the surrounding environment that may have clinical benefits? One of the simple things to do, I mean, we live in a tropical country here in Singapore, and an important point about this particular study is that we started the study in Singapore in 43 individual homes, found the signal, and then repeated that very experiment in 12 homes across the globe in Vancouver, Canada, which demonstrates seasons, which is in contrast to Singapore and has a completely different climate. We're able to reproduce the same result with the same organism. So I think coming back to the origin of your question is that what interventions can we make? I think the interventions in Singapore, for example, is we have a tropical environment. So perhaps opening up your windows more frequently than using air condition or fans indoors will alter your indoor air microbiome to make it much more like the outdoor. We can have other environmental interventions that will need to be tested before we can make any conclusions as to clinical benefit. And one of them is air purification. Will air purification remove spores of fungi, and will that have clinical effects? Well, there's an interventional study to be done there to answer that question. But I think in the context of climate change, which is clearly happening and extreme weather events becoming more frequent, I think we're going to have to start to look at environmental interventions to at least augment, if not help, with management of our respiratory conditions such as COPD.
Just thinking about this study in the context of some of the other studies that you've published in the ERJ, it's always nice to see a story evolve over a number of years. And I think that's one of the reasons why we were really keen on this paper. A lot of people, I think, still wouldn't think about Aspergillus sensitization in the context of COPD. So we think about it in patients with asthma, we think about it in patients with bronchiectasis. But the GOLD guidelines or the GOLD strategy, I don't think it mentions sensitization to Aspergillus once. So this seems to be an under-recognized issue. You know, for the listeners who are hearing about this for the first time, how big an issue do you think Aspergillus sensitization is in COPD? And should it be something that we're looking for routinely in our frequently exacerbating COPD patients the way we do in bronchiectasis?
I think there's accumulating evidence to suggest that, yes, it is something that we should be looking for. I think rates probably vary in different parts of the world, as ATP patterns do. I think environment, climate, geography plays a role. I think host genetics plays a role. I think the origin of the COPD plays a role. And so I think there are multiple factors here, and we're only at the beginning of that evidence base before we can really translate it into guidelines or actionable clinical interventions to give us the evidence we need to conclusively say that, look, there is a signal here, we need to be looking for it. And in the context of what you mentioned about the pipeline of papers that we have fortunately published in the ERJ, I think it's worthwhile spending a minute to just have your listeners understand how that evidence has been accumulated. I think it began with asking the question of, are COPD patients reacting to outdoor air microbes? And what we found was, in fact, they were, and they were mainly fungi. That then evolved into a second group of papers, which then showed that there were microbiome signatures. And microbiome, for the listeners less familiar, is the fungal aspect of the microbiome. And in fact, we found microbiome signatures in a subgroup of COPD patients that put them at higher risk of a poorer 2-year outcome in the context of mortality. So there was fungal signatures there that indicated that patients with COPD were going to have a less favorable clinical course. And then the third group of papers that were published really looked at how we detect this sensitization or these responses. And in fact, what we use in clinical practice are crude allergens in your immunology clinics in most hospitals around the world. And what we did in the third paper that was published last year was, in fact, looked at a whole range of 30 to 40 very specific recombinant allergens and found that there were a number of COPD patients that were positive on the specific recombinant allergens, but were negative on the crude allergens. So in your clinic, that patient will look negative on the screen that's been done. However, if you do the more detailed, very specific screen, they will be positive. So I think that it is probably out there. We're missing it. We're underdiagnosing it because we don't necessarily clinically implement the tools necessary for that diagnosis. And then this most recent paper shows that the indoor environment is a really important source of that. And I think that's exacerbated in countries where the climate is tropical.
We have a lot of patients that have COPD with frequent exacerbations with limited treatment options. So I think an important body of work that's telling us that fungi may be driving disease, at least in some patients, and opening the way to studies that could potentially then test interventions to see if treating that is a way of preventing COPD exacerbations. So great work, and thank you for publishing it in the ERJ. In the last few minutes, I want to switch gears into the review that you've published with us on the broader topic of fungal lung disease, which I think is still a mystery to many in our respiratory field. What do you think are the key hot topics that you were keen to highlight in that review in fungal lung disease at the moment?
So I think as we've just been discussing that, fungi and fungal sensitization in context of COPD has been under-recognized. I think more broadly, fungal lung disease is a topic that is less focused on compared to other types of lung infection or chronic lung conditions. So I think fungal lung disease is a really wide spectrum. The fungi go far beyond Aspergillus, which we've been talking about. There are lots of fungi that play a role in the lung. And I think that really the spectrum of fungal lung disease is really dictated by your geography and by the state of the host immune system. So you go all the way from somebody who is grossly immunodeficient, who has invasive fungal disease that perhaps, is linked with very high mortality rates, to somebody who's immunocompetent but yet has fungal lung cavities in their lung, which they've been predisposed of because of past TB or other chronic lung diseases that have destroyed the anatomy of the lung. And then you have the other end of the spectrum, which is an overexuberance of the immune response that results in things like sensitization or even allergic bronchopulmonary aspergillosis or allergic bronchopulmonary mycosis, which in fact is the complete opposite end of the spectrum. So one thing to appreciate with fungal lung disease is that you can have a single patient at a single point in time that demonstrates one. And as their immune status changes, as simple as giving a course of steroids to a COPD patient, they can switch from somebody who's looking like having sensitization to somebody who's at risk of chronic pulmonary aspergillosis because of the mild immunosuppression. So I think the complexity of this and the spectrum of it is now much better recognized. And I think the hot topics are really, can we get better diagnostic clinical markers in order to pick up these conditions at various points in time, at various clinical courses of individual patients, from the ICU all the way out to the outpatients. And I think next generation sequencing is really helping with that. I think the second really hot topic is novel antifungal therapies, as well as the emergence of antifungal resistance. So we all know about antimicrobial resistance and the dangers that brings and the global challenges that brings. But in fact, fungal resistance is also on the rise and is arguably an even greater issue than bacterial resistance because of how much we don't know. And I think that using the advancing technologies that have been coming on the scene, which we do review in this article with a team of authors from across the globe, we try and contextualize where we think this field is going in terms of new diagnostics and new therapeutics.
Yeah, so I think really critical review, and that's why we were so keen to publish this in the ERJ. Big problems in fungal lung disease with recognition of the patient, so underdiagnosis, difficulties with the diagnostics, and as you say, difficulties with the therapies, not just with resistance, but also tolerability and drug-drug interactions with the therapies, making these very, very difficult patients to manage. So the review, I think, is timely and important for our readers that might be looking after these patients. So Sanjay, that's been a fantastic whiz through two important papers that have just been published in the ERJ. I want to thank you for speaking to us today and contributing to the ERJ and to the ERJ podcast.
Thank you, James.
Thank you all for listening. We do this podcast every month highlighting new papers in the ERJ. So join me and my Deputy Chief Editor, John Singh, every month to learn about what's hot in respiratory medicine from experts in the field like Sanjay. So see you next month.